Angeles, Nelson Hardiman. Harry is considered one of the foremost experts on the opioid addiction, and what's interesting about his book is he lays out all kinds of solutions to the problem, which are being increasingly implemented in the cities that are most successful in combating this epic problem. So we're very excited to have you, and know that it will be a wonderful program. The people who are on either side of Harry are known to most of you here. Harriet Rossetto, who is the founder of Beit Teshuvah, an amazing woman. And while I know I'm preaching to the choir, Beit Teshuvah is a remarkably unique and successful agency, which is a 140-bed recovery center. In addition to, by the way, it's a recovery center that uses a lot of the strategies that are most successful, determined to be most successful: spirituality, psychotherapy, and community. And those of you who are part of this community in terms of in residence can attest to the comfort you receive and the support you receive being part of this community. And to that we are extremely indebted to our founder, Harriet Rossetto, who's a remarkable woman and a great friend. On the other side is our founding rabbi, Rabbi Mark Borovitz. Mark is an amazing person who has for many years, for 30 years, instituted and run our spiritual program here and our synagogue. This is a synagogue. For those of you who aren't members, we urge you to join. It's an amazing community, recovery community, and a synagogue. And what Mark is doing currently is managing and directing our Elaine Breslow Institute, which is an educational arm of Beit Teshuvah, which not only presents programs like this, but also trains and certifies rabbis, educators, and doctors nationwide who come here for intensive training to deal more successfully than they have in the past with issues of addiction which arise in their communities. So it's an amazing program that you will be hearing more and more about as we further develop our Speakers Bureau and speaking lecture series. So we're indebted to you for everything that you have done and will do. And with that, I would now like to turn over the program to our moderator, Rabbi Mark Borovitz, and thank you again for being here.
We are live streaming, so anybody who's watching live streaming, hello and welcome. If you have a question, I think you can send a text. Is that right, Zach? You can send a text and we will answer your questions. The format of this is going to be, I'm going to ask some questions and get a conversation started and then open it up as well. So there's another mic back there that Thea's going to handle, and whenever you have a question, when it's time, you'll raise your hand and we'll call on you, okay? So I want to start off with, first of all, thanking you, Harry, thanking you for this book, thanking you for being somebody who's cared about good health care for people for so many years. And being we're a client of Harry's as well. And how do you draw the line? This is for opioids, this is for all of these things, between what the law says, which are usually antiquated and stupid, in my opinion, and what's best for the client patient?
A tough question to open with. So, well, first of all, I just want to say thank you for having me here. It's really an honor. I'm humbled to be here, so thank you. So,
by the way, we did not practice these questions at all, in case you haven't noticed.
So if I can actually use that as an opening just to talk about the challenge for everybody facing the law. One of the things when we sit here today that's amazing to think about how much change has happened in the last couple years It was only in 2008, 11 years ago, that the federal government passed the Mental Health Parity and Addiction Equity Act, which was the first time that we said as a country that we're not going to allow health insurance companies, which play a huge role in deciding what the care actually looks like, not to discriminate between medical, surgical care and mental health and addiction. And that was a huge step forward. It really changed my life as a lawyer, because the question came up of, well, what does that mean? You know, what do we get to? I had addiction treatment doctors and programs asking, what can we do now that we couldn't do today? And then it went a big step further with the Affordable Care Act in 2010, which basically mandated that every health plan in the country, whether it was a private insurance plan, an employer-sponsored plan, Medicaid, was required as an essential health benefit to cover addiction treatment. And so the law has changed radically. And just to go one step further about how challenging it is when we think about our laws, when I came out to California in 2001, for the first few years I defended several cases. I would defend doctors who were treating pain, and these doctors were being prosecuted for under-treating pain. And if you know anybody who's in pain today who's trying to get treated by a doctor, good luck, right? It's doctors are really living in a climate of fear because of the way that overprescribing has become the biggest boogeyman out there. So it's an enormous, enormous challenge to figure out whether you're a doctor, a mental health professional, a treatment, residential treatment, outpatient program. The rules are so complicated, and the biggest challenge that I see is that the clinical professionals, many amazing professionals with Beit Teshuvah who are here today, have a evidence-based clinical therapeutic approach. The laws say you can go here but not there. We put the medical aspect into one bucket, and we say it has to be done in these settings. We put the treatment, other parts of the treatment say it has to be done over here. Beit Teshuvah can do this, not that. And then you add the insurance layer, and it's almost like a game of three-card Monte with, there's a point where I spend a lot of time working with people on how do you decide what you're actually going to do within what, that's not going to get you in trouble with the state on your license and on the insurance. But it's a moving target and not an easy question.
Okay. So you wrote this book, United States of Opioid. And what drove you to write it?
So I share in the first chapter of the book having this experience. Most of the people who do the work I do, we look at contracts, we read regulations, and it's not exactly, life and death. It doesn't have a life and death feel. I had an experience about 12 years ago where I was working on a case. I worked on a number of cases involving celebrities, which were different only in that the media attention and the political pressure was just created a firestorm for the doctors involved in some of these cases. And I had a case where a doctor called me in a panic because he had prescribed to a celebrity patient in a fake name, and I was trying to calm him down, which is part of my work as a lawyer/therapist. And before I could get him into my office the next day, I found out that he took his own life. And that was sort of a wake-up call to me of that the ways that our laws, what our laws allow, what our healthcare system prioritizes and stigmatizes was actually literally killing doctors. I've had conversations. There's Dr. Jerry Abraham is here from USC, and we've had conversations about the way that physician suicide is a real problem related to this crisis. So part of it was a beginning of a wake up for me, and then what began to happen as I started doing more and more work with treatment programs around the country was I became known for doing the cleanup work after an overdose or a suicide, and it became almost a week in, week out activity. And I said to you, I would get a call and they'd say, what do we do? And I'd say, okay, here are talking points for how to speak to a family that just lost a child. Here are talking points to talk to the residents who have been traumatized by this horrific event. Here are the talking points to talk to your staff. This is what the state is going to want to know and hear about how you're going to change things, that led to this. And it was absolutely a horrific feeling that I was literally like, what's the Quentin Tarantino movie with the cleanup, with the person who comes in after the crime scene? The wolf, thank you. Thank you. And I started to feel like a lawyer version of that, and I felt like it was important to say something about what was being done, because the more that we stay reactive in this crisis, the more we stay in this horrible position where we find ourselves.
Thank you. So you have solutions in your book, and of course, Harriet's been doing this for 32 years
Correct.
at Beit Shuvah.
Before anyone knew there was an opioid crisis.
Right. So how do you define success? I'm going to ask both of you this. How do you define success, or how would you, in dealing with this opioid crisis? Harriet, why don't you go first?
I'll start.
Okay, good,
Okay.
because you had the microphone there.
Yeah. And this is something we struggle with all the time. I call it the tyranny of metrics, of measurable objectives, of trying to find one way to define success when you're dealing with a condition that is nuanced, that is different for everyone, that there can never be a one way. And I think we get hooked on measuring success by just length of time, by sobriety. We don't differentiate between the symptom and the disease. Addiction and recovery, addiction is the substance or the activity that people use to mitigate a sense of pain that they're feeling. And it can be measured by the length of time sober, but that's only half the story. Recovery is a lifetime process, and that treats the disease, not the symptom, the underlying conditions that cause people pain, loneliness and disconnection and isolation. And those are not easy to reduce to a formulaic measure of success. That's our struggle.
I don't know how you'd begin to define success. What I saw, I had the privilege as I started talking of sitting at the table with the lead policymakers at all of our federal agencies that touch this crisis. And what I saw around the table is that the way that the crisis is being approached right now is a question of how do we put more naloxone, more Narcan into people's hands so that we have fewer overdose deaths, right? How do we have better reporting of physician prescribing so that we catch higher prescribing? How do we get more buprenorphine access, for medication-assisted treatment? What I didn't hear around the table, and this is what part of the other piece of the book for me was, I didn't hear anybody talking about how do we actually bring the numbers down. Because we go back, the opioid crisis is, most people count it as 20 years, but if you look at the data, we have 40 years of an exponentially increasing year-over-year overdose death crisis from all drugs. So I don't think we solve the opioid crisis if we just, transition people from OxyContin to fentanyl, or from fentanyl to meth. And we need to really, the way we solve this is by actually beginning to ask the question, which isn't being asked. It may be being asked here in Beit Shuvah, but it's not being asked. The question is not even being asked yet in Washington, D.C. of how do we bring down the overdose death toll and create effective addiction treatment.
The research that we did with UCLA here, Dr. Sergio Fontanesi was our head researcher. He is now full-time employed here at Beit Shuvah as Director of Clinical Services. The conclusion was that connection to community and relationships and willingness to sustain the process of recovery are the magic sauce of what works at Beit Shuvah, and I think addiction in general. And Johan Hari, who wrote the book Chasing the Scream and Lost Connection, said the opposite of addiction is not sobriety. The opposite of addiction is connection. And I think universally, people are suffering from loss of connection to themselves, to their families, to a sense of meaning and purpose, and to community. And our challenge is to reduce the demand as well as the supply.
But here's the deal, okay? So you're a member of B'nai David, right? And you're a member of Beit Tshuva, Congregation Beit Tshuva. Why should Jews care? Don't you understand? We don't have that problem. Shiker's a goy. That's the phrase. I can't tell you how many parents I hear. I don't know what happened. I mean, you know, I can't tell you how many rabbis, how many synagogues. It's like we don't have that problem. So why talk about it as a modern Orthodox Jew and as a Jew? Just Jewish Jew.
A reluctant Jew.
Reluctant, yeah. Why should Jews care about this other than the idea of, oh, yes, we want to help those poor people?
So, you know, the place where it really hit home for me about this question of, you know, why are we, what the Jewish community was actually in a church. I was invited to Saddleback Church down in Irvine, and they had a big billboard behind the prayer service that said, "You are more than enough." And I don't know, maybe you say those words here at Beit Teshuvah, but I can tell you, as the son of a rabbi and having spent my whole life in Jewish organizations, I have never heard that message, right? I asked Rabbi Steve Greenberg, who lives on the East Coast, and I said, you know, why don't we tell that message? Because I think you're right. I think the core issues are all connection, shame, and he said something to me really powerful. He said, you know, it's easier for evangelical Christians as a religion of grace to give that message and to say to people, you are more than enough. And the message that we as Jews have is, you need to be more, you need to do more, you need to be more successful, you need to give more. We load down. We are a religion. We are not a religion of grace, right? We are a religion, and and I think that
Wait.
we are. Well, my point is, like, we push each other, and we accomplish amazing things, but it also means that we don't have a place for disability. We don't have a place for, we're not good at these messages. And I know I'm sitting here in an island, but if you look nationally, there just aren't. Beit Teshuvah is an anomaly, and I think it speaks to the fact that we, as a broader Jewish community, we struggle with how to incorporate and integrate this into our community.
Couldn't agree more, but I think
Oy.
we have to differentiate Jewish religion from Jewish community. Because I think our religion, if interpreted the way I would like to interpret it, is a religion of grace. I think as a Jewish people, maybe an oppressed Jewish people, we have become addicted to perfection and to hiding our imperfections and to living in shame of not enoughness. But I don't think that's what our religion teaches us.
Well, you know, the name of this place is Beit Tshuva, House of Tshuva, repentance, return, and new response. So, what could be, Rabbi Heschel says, the most unnoticed of all miracles is the miracle of Tshuva. So, a religion, a faith, a way of living that's based in, we're not perfect, and we get better each day. But the fact that we say, Modeh ani lefanecha, every morning, I'm grateful to you, God, for returning my soul to me with compassion. Great is your faithfulness. That already is total grace. So, how do you deal with the Jewish communities, this is again for both of you, that don't want to hear the message as pertaining to them?
So part of it for me is that we have to, when we look at the opioid crisis, it certainly has been worst in the places of poverty, in the places of unemployment in West Virginia, in Southern Ohio, and I think we need to look at the way that the opioid crisis is part of a much broader, deep social crisis that looks different in our communities, right? And it extends to across other drugs, but it also extends to these parallel rises in anxiety, depression, suicide. This is a much bigger thing, and I think we need to, it's interesting. I spoke to another rabbi, and I said, we really have to attack shame in Jewish life. And he said to me, shame works, right? Shame is what gets people to show up in synagogue. Shame is what gets people to give. And I think the question is, how do we actually make it, you don't have to convince people that the problems are thick in our families, in our communities, but we need to figure out how to get past the toxic shame and create a way that people can actually communicate with each other without judgment around them.
I think one of the things that the opioid crisis has made clear is that there are no exemptions to this disease. And what we're seeing here, and I think it's a national problem also, is the rise in addiction among the affluent and among young people. And affluenza has become its own disease, the diseases of too much and of overindulgence. And I think it's getting more difficult for the community to stay in denial. And we have been a community of denial. Working with families is trying to penetrate the denial of not my kid. And it's difficult because denial has kept us in some way protected, I think, from looking at the parts of ourselves that we don't like.
So, I have so many things rolling around. So where do we go from here? The big thing in treatment is Suboxone, medicated assisted treatment, which we at Beit Tshuva are not against, we just don't think it's a long-term solution. And in families, it's still shame and denial. Rabbis are not really talking about it on high holidays, and they don't really practice tshuva as a community. So, you've been speaking all over. You've spoken all over. Where do we go from here? How do we get out of the box of one way? Harriet mentioned it before, but this idea that there's only one way to do it. I can't tell you, insurance companies don't want to pay for treatment if it doesn't have Suboxone or detox. And Medi-Cal says you have to do all these different things and only this will work. And I speak to doctors and they say, oh no, Suboxone is the only way to help opioids. Now there's a lot of other addictions that a lot of other substances people get addicted to. So what's the way forward when everybody wants a stupid, simple, one-way solution?
So
that was a commentary, by the way. Stupid was my.
So I think we're in the very beginning. We're in the first inning, if you'll take the analogy, of changing awareness and actually having a real conversation. So I said at the beginning we're 7 years into insurance covering addiction treatment. So one of the things that's most disturbing to me that you're alluding to is that there are these completely siloed conversations. So if you spend time in the addiction medicine world, with groups like the American Society of Addiction Medicine, and this is also true in the policy conversation, the discussion is all around medication-assisted treatment, which has been one of the few data points that has actually reduced the overdose death toll has been the spread of medication-assisted treatment. And what has been striking is that if you spend time in the addiction treatment and recovery community, the approach has which is really what was the only group out there actually paying any attention to this, was the community of people in recovery and the community and offering recovery resources. It was a non-medical conversation, and what happened is, and just to be cynical for a second, is part of what the Affordable Care Act represented was a huge pile of money, right? And you have a competition that goes on for it between the medical establishment offering medication-assisted treatment and the treatment and recovery community offering social model recovery, right, which is really what Beit Teshuvah embraces. And I think the answer, the beginning is to have a real conversation, because what scared me, one of the things that shocked me, I was sitting around the room, I get invited to a meeting in D.C., and they go around the room, and the person next to me says, they ask for introductions, I'm the head of policy at the DEA, I'm the head of policy at the Substance Abuse Mental Health Service Administration, and I'm going, wow, this is, I'm in a great company. I'm the head of the National Institute of Drug Abuse, Office of National Drug Control Policy, and so on around the table, and a bunch of addiction medicine doctors from leading schools. And I noticed not a single person from the recovery community. And it became clear to me about 20 minutes in, I was the only person there coming at all from a recovery and social model perspective, which is ironic, because I'm a lawyer who works with these programs, not you guys are the real deal. And the conversation isn't happening. And so the first thing that needs to happen, and I hope this is one of the reasons I was thrilled to be here today, and I hope one thing people will take away is it begins with awareness and actually beginning to participate in the conversation, because our policy is going forward whether or not you participate in it. And the only way that that we begin to integrate social model and into the conversation, which is ironic to say, given that social model was the only thing there was for so long, is by people actually insisting on it being part of the conversation and changing the conversation.
So how do we get invited to the table?
I think it's a conversation about supporting advocacy groups. It's about showing up in Washington and in Sacramento with groups like the California Consortium of Addiction Programs and Professionals, which I know Beit Teshuvah is part of, but really showing up and doing the work there and doing the work in D.C. Groups like Shatterproof, and I'm just picking out a couple. There are many more who are doing the work, but actually getting support for those from really not having this just be a few people at the table. I'll tell you just at the risk of boring you with the way the advocacy works. When a law comes up in Sacramento, there's a folder that gets put in each committee of who submits a letter of support. And I can tell you one of the big issues was a bill to get insurance companies to pay addiction treatment programs and not to pay to the patients, right? That was because you'd have people in recovery getting checks. And when that bill came out, there were 2 letters. I know because I wrote one of them, but the last time that bill was circulated, there were 2 letters in favor. I don't have to guess how many the insurance companies had on the opposite side. So I think there's a lot of work to do of real advocacy.
Well, great. So, one of the things that I'm getting from this is that we need to work more to figure out how to do that. And we would love your assistance, without a doubt. I'm going to open it up for other questions. I've got some more, but Thea, over there. Hold on for 1 minute. We need the microphone. We're live streaming this, so that's why I want to have microphones.
Hi, anti-alcoholic. Thank you so much for being here. Just to piggyback off of the insurance question that you talked about, how much does body brokering and vet vouchers and all of that stuff lead to more of this opioid epidemic? I know so many kids that have died at the hands of body brokering. How do we deal with that? I work in compliance, and I immediately terminate relationships with companies that I help get licensed and stuff when they stray because their census is low. And all of a sudden their morals or ethics seem to go out the window. How do you deal with that? How do you approach that? And how big is it nationwide?
It's a horrific problem. This is something I actually spend a lot of time on the book in. This is an area that I've done a lot of work in. I actually put together a program for ethical addiction treatment marketing. So the way I've been working as a healthcare lawyer for about 25 years, and what I see over and over again is a cycle of which body brokering is only the latest and most horrific chapter. And what happens always is that a new reimbursement opportunity opens up, right? And I'll give you an example in a second. And then people, there are going to be innovators who move towards it and profiteers who move towards it. And what happens is the profiteering just draws more and more and more, and it gets worse and worse, and then the insurance companies stop the opportunity. So, and a good example of this happened around, before we got to body brokering in addiction treatment, we had it around urine drug testing. And what happened was, about 12, 13 years ago, the studies were coming out about opioid dependency, and it was in the workers' comp arena, it got a lot of attention. And so there started to be guidance from national trade organizations that doctors treating people in pain need to do urine testing to make sure that people are not either drug seeking, meaning they're taking whatever the doctor's prescribing them here plus whatever they can get on the street, or drug diverting, meaning they're selling the drugs for their street value. And so that was the recommendation, and it was a good recommendation. The problem was that there were the number of companies that sprang up to make money on getting doctors to do the tests so that they could bill them for thousands and thousands of dollars. Overnight, we went from a system that was paying for $1 million of drug testing nationwide to like 500 billion, like literally in the course of a couple years. And so when that opportunity, that day when in 2012, January 1, 2012, when the Affordable Care Act mandated that every insurance program in the country cover insurance, it was both an incredible thing for access, to get people access to care, but it was also a feeding frenzy for fraud, for body brokering, and for people making money by directing people. And it's a horrific problem, and it's one that needs that I think in some ways it got lost because people in addiction treatment addiction treatment was never part of the healthcare system. It was sort of disconnected from healthcare, and so it took a little bit of time to figure out what was going on, but it's a horrific problem. It's still going on aggressively. I could show you. You could Google Beit Teshuva, and you'll find like marketing companies that will use Beit Teshuva's name to drive people to other programs. And the death that has resulted is horrific. The waste of resources and the human suffering of people not getting the help they need is a tragedy.
And I think there are worse things even than body brokering because of bureaucratic and insurance rules for medical necessity. There are programs that actually get people loaded so that they qualify for medical necessity under those rules. Because if you've been sober for more than 3 days, you don't qualify. I mean, it's insane.
Oh, the worst practices. I mean, you could go on and on, but I mean, I've dealt with at least, I would say, about once a month a program that has a mole. A mole is a patient who comes into an addiction treatment program to pull existing patients out and tell them, if you just use again, as long as you're willing to use drugs again and give a dirty urine, then we can get you into this program that's going to have a hot tub, and I've had people been taken on planes from California to Florida, and then the other piece of it that is the horrific is patients being paid to go to treatment, and I can introduce you to families whose kids were who are dead after 3 to 4 programs. It's absolutely horrible.
For any of the residents sitting here that just heard that, don't go.
Right. So just to piggyback a little bit more on this idea, how do we, the people here, people listening, how do we call this out, put a stop to it? I mean, there's been body brokering for more than just the past few years. I can tell you, I know when we were still down on Lake Street, there were people who would come and say, listen, if you'll pay me a referral fee, I'll get you paying clients. I mean, this kind of thing has been going on for a long time. So how do we do something to stop this? Not just legally, but how do we get enough information out to these poor families? Because if somebody's in trouble, they're going to hold on, and somebody says, I got the solution. They're going for it, and especially affluent families, going back to what Harriet said. Affluent families are paying a ton of money for false promises. How do we do something about that?
By the way, this problem is so serious that we passed a major federal law last year, the Eliminating Kickbacks and Recovery Act. So that's what the government's doing. But I think what needs to happen is we need to start educating people before they get to that point where your child is using so that you create an educated parent body who are sophisticated about every step along the way. At what point, what the options are for intervention, how the different pieces work together. Because I talked to one family after another who basically it was only on the third stop that their kid made that they started to actually understand the differences between the programs and what was actually being offered. And I think there are good and bad programs out there, and I think there needs to be education that starts when people are young parents, long before their kids hit. I mean, one of the things the opioid crisis did is it showed that the problem was, it called attention to the fact that middle schoolers are now the prime population, right? That was a new learning, that 12 years old is really like a beginning of an at-risk age. I think we need to be educating parents when kids are 5 and 7 so that we actually understand this world. And again, so that awareness piece is, to me, the first step.
Great. Leslie.
Just backing up a little, what is body brokering?
So body brokering is basically marketers getting paid to bring a patient to a program. So it exists. It's a kickback in healthcare. The problem of kickbacks is an old problem, right? There are people who will pay doctors. Treatment programs can pay to have people send them patients and then bill those patients to insurance companies, and that can be a really profitable business. So we've had that problem of people being incentivized to send patients to programs that aren't good for them and to things that aren't for a long time. But in this area, so it's we've had this phenomenon around the country of addiction treatment programs. Not what you would think in a normal system would be is that there'd be addiction treatment programs like Beit Teshuva would hold themselves out, and people who needed help would go online and find resources. But instead, when you go online and you put names into Google, what you end up with are marketing services which are full of people sitting at computers trying to figure out if they can sell that patient, talk to the family, and sell and get a patient who they can sell for $5,000, let's say, to a facility. And there are people driving fancy sports cars and living in mansions in Florida and California that were made on this kind of human trafficking.
Dr. Friedman?
Hi, great to hear you. David Friedman, psychiatrist, and somewhat of a gadfly in this place because at times. I don't like everything that ASAM recommends, but I do like their definition, and it's an all-encompassing definition. And this is a biopsychosocial spiritual disease, and I think the beauty of Beit Teshuva is that it addresses all of those factors in an integrated fashion. But if we conceptualize addiction as a biopsychosocial spiritual disease, my concern is that the current cultural, economic, political world in which we live makes such things that are being recommended as advocacy, education, increasing connection, increasing hope, extremely difficult. And I was here Friday night, and I heard Rabbi Mark give an impassioned drush about what we as Jews are about and what our fundamental values should be. And my concern is that see fundamental changes in the way our government operates, and in terms of the people who are running it, that everything, to my estimation, about what we currently see in government at the highest branches of government that pertain to deceit, corruption, dishonesty, lack of the real values that we seek to inculcate in people in recovery. That as long as that's happening, how are we going to institute any of these changes? Now, the ACA took a wrestling match by Obama for years. And even at that, you know, one senator was able to put the end to the public option. Joe Lieberman, he came from Connecticut. What do they have in Connecticut? Insurance companies. So I think that any discussion of this problem that does not include attention to income inequality, to hopelessness, to the kind of things that allowed Trump and his people to win the election. But remember, he only lost the popular vote by 3 million votes. Now, I think that my feeling is that any potential notions of what do we do about this addiction crisis and the broader crisis of mental health problems, anxiety, depression, suicide, if it does not, and I know this is difficult to get into politics, but if we don't address that additional aspect of things that would basically is what governs all else. Politics is everything. Government policies are everything. And I'm wondering if you have addressed that particular concern in the book.
So I came away from those conversations in Washington convinced that nothing was going to happen. By the way, you know, I wrote a book before this called From Obamacare to Trump Care, and if you think anything is going to happen in Washington after in the current environment, listen, you know, of paralysis and toxicity, and you know that you're a much more optimistic person than me. But what I said in the conclusion I came to that really I laid out in the book is that the only way we're going to address what you're talking about, David, is really outside of policy. We're going to do that in community-based partnerships, right? So it's going to happen in faith communities. It's going to happen in schools. It's going to happen in the workplace, and it's going to take a lot of work away from Washington. And I think, to me, the most exciting opportunity that Beit Teshuvah presents is having been as just a reservoir of learning and teaching to go out into our schools, workplaces, and faith communities, because it's only if we actually carry that out of the islands like Beit Teshuvah that we're actually going to do anything.
There's a lady, Thea, there's a lady in the back.
Mark, I just want to say to David, we're going to continue to help one person at a time while Washington is doing. We live in an alternate reality now, you know?
Yes, ma'am. Hi, Janie.
I'm interested in going back to the middle schooler piece. I work in prevention, so interested in kind of addressing things before they turn to an issue, and I'm wondering, in your guys' opinion, what should the focus of that work be? Like, you mentioned connection, I know focus of education. In your mind, what would be most effective when trying to intervene before it starts to take hold?
We have a prevention program we've had for years. Prevention is different from drug education. We're not addressing kids in terms of this is your brain on drugs. We're trying to help surface the kinds of things that young people feel in middle school that lead them to addictions of one kind or another. The sense of, I'm not good enough. There's no way I'll ever be good enough. Hopelessness, meaninglessness, lack of connection, lack of authenticity, the kinds of relationships that are role-driven, not soul-driven. And that, I think, is the approach to prevention. And I think there needs, what I hear from you, what I know here, is that prevention is probably the most important thing right now in this whole picture.
I would just add, I think we're beginning to see a shift in prevention. I know Santa Monica schools, for example, are teaching mindfulness. So I think there's a lot to unpack in the conversation around what mindfulness means, and like redefining wellness to include a spiritual, social, emotional piece. You know, one of the things I've learned, I'm not an educator, but as a parent, is that resilience, resilience really it has a much broader meaning in this context, I think, than just, I always thought of resilience as my kid comes home, didn't get the part in the school play or whatever, how do you get them to move on? But I think the critical piece that I see that we need to teach our children is, how to deal with the attentional fixation on these states that we're all going to go through, right? Of the sadness, the fear, the sense of being overwhelmed, the anger. Those are real things that middle schoolers are dealing with. And how do we actually get them? How do we give them the tools and the awareness so that they have resources to not be attentionally fixated, and the support to get out of it through whether it's through connection, through purpose, or through coping mechanisms.
Yeah, and I think that there's another piece here, that our parenting skills have to change. My father, Oliver Sholem, all he asked of us to do was the best we could do on that day. If we could say we did the best we could, didn't matter what the grade was, didn't matter what happened in the game, none of it mattered. And so if you're talking about middle school and in rural and affluent, okay, all along, the problem, I think, starts at home, where everybody is so, poor people are so taxed with, how do I make enough money to pay the rent and feed my children? Very affluent people are taxed with, they feel taxed with, how do I keep making more and more and more? And nobody is saying to the kids that we named you whatever because we saw this trait in your soul, and nobody's raising that and teaching parents to raise that. Harriet, you wanted to say something?
Yeah, I think one of the most important things I learned from Doug Rosen, who runs our prevention program, that I had never thought of. He goes around and talks to parents, and he said, every night at the dinner table I would hear from my parents, we only want you to be happy. And he said, that was such a burden to me, that if I was not happy, I felt I was letting my parents down. And so I never learned to be okay with not feeling good, with expressing sadness. And that was that's really counter to everything we think about, in terms of parenting. We only want you to be happy. That's not maybe the most helpful thing you can tell your kid.
Somebody in the back has their hand up there. Hi, Michael.
dead because they weren't paid any attention to or being driven to commit suicide because they're advertising treatments they have no clue how to deliver. I'm really glad to see you here and raise these issues. I'm familiar with Shuba. Dr. Gary O'Connor is a long-standing friend of mine. Last year at his celebration of life. And he really knew how to treat this disease, and he's been was a mentor to me and many others I know. And Harry, you and I have met, and I think we're going to be working together in the next month, so I'm really thrilled to be here.
Thank you. You know, I want to say something about that. And you can please comment. Dr. O'Connor, Garrett, a blessed memory.
4 years
4
since
years.
he died
He's
today.
dead 4 years now. So we had, you knew Garrett, so you knew how quiet he always was. And I'm a rabbi and a Jew, so of course, you know, I'm very low key as well. And we would get into conversations in restaurants all over and just start screaming at each other. Not that we disagreed, but just that we would scream at each other. But Garrett's thing was, most of the people who are on some type of medication, it enhances, it detracts from their sobriety. He believed that there were times in individuals where medication absolutely was necessary for their sobriety and their recovery, and a great deal where it harmed them. So I love what you're saying, but again, how do we get to seeing the individual in a system that wants to have one size fits all? That's really the question, I think, that is, for me, is underlying all of this. And I don't know how to make policy like that. I just know that if every Jew is responsible for every other Jew, and every human is responsible for every other human, then, and all of us are unique according to Sanhedrin, then how do we get insurance companies, government agencies, people, just people, to understand that, Harry?
I think that's another book.
I'll write it with you.
I would be honored. I think there's so many. I think part of what this conversation highlights for me is that we're still living in a real time of transformation. By the way, this conversation about medication-assisted treatment and abstinence-based models is a reflection of it, because we're still coming to grips. There is with what actually works. I know people. I used to be very more outspoken negatively about medication-assisted treatment, but two things. Number one, I had people, good dear friends, come to me and say, my daughter's only alive because she's taking Suboxone every day. And if you think about it, there's a level of shame, right? Can you show up at an NA meeting if you're on are you welcome in the room if you're taking something that a doctor prescribed for you? So we have work to do to unpack this. I think that there's a lot you could say about to your question about how this gets fixed. It's a lot of sausage making ahead of us. I think the important thing is more people understanding it and more conversations. One of the things that really blew me away was the extent to which insurance companies, of which I'm not a fan, but they're just part of they're the reality of our system for the foreseeable future. They started saying, we want to come on site and see what's being done at this treatment program. Right? That's something that never happens. The insurance companies don't say, we want to come to Dr. Smith's cardiology practice and see what's going on there, right? So I actually think the conversations and the sharing of information here between treatment programs and insurance companies with government, that we're moving in the right direction. It's just that we're really early in this process.
Harriet, how do you get to both hands?
Yeah, well, I think that policy, by definition, can't individuate. It has to find a one way. It has to be measurable objectives. And that's not what real people are about. So I don't think it's going to happen from a policy-driven direction. I think what you said before, that community building and the Weaver idea of small communities dealing with people and individuating treatment is the way the change is going to happen. I don't think it's going to happen from the top. And I think that
Right.
because there's so many different ways, and it is a both and. It's medication-assisted treatment, it's spiritual connection, and it depends on the needs of people. Not everybody wants to come to a place like this and spend a year looking at themselves and finding the depth of their being. Sometimes they just want to take a pill so they can go to work, and that's okay. But I think knowing who needs what is the most important thing that we have to figure out.
Right, and I think being able to offer all of it. So where the legal part or the government or the policy comes in is that policy gets us into very narrow spaces.
Yes.
And what I'm hearing from Harry, which is really exciting, is that there's ways to expand the policy to be more than just what SAMHSA says is the only measurable objective, 6 milligrams of Suboxone a day, and that's the appropriate dose, et cetera. And maybe somebody needs 3, maybe somebody needs more, I don't know. But this whole sense of if we don't have policy going along with what is happening on the ground, then what's happening on the ground leaves us open to a lot of legal problems, right?
Yeah, just to piggyback on that, I spoke to a couple people this morning. In the New York Times this weekend, there's been a coverage of what's going on in Seattle, which has been one of the most progressive American cities in terms of really embracing a harm reduction approach with decriminalizing drug possession and drug use, and really focusing every time law enforcement come into contact with people with an addiction, trying to offer them and encourage them on the path towards treatment and recovery. And I want to just highlight that, that's widely accepted across Canada. It's in every Canadian city. It's being widely used in Europe. Ironically, the model developed here in Santa Monica at the Rand Institute took it over to Portugal in 2001. So we're 18 years into experiments of whole countries having embraced that model and it working, and yet it is far from accepted in the United States. It's so controversial that the federal government, Department of Justice, is suing the city of Philadelphia for embarking on a safe injection site, supervised injection site, where people who have heroin can come with their heroin, make sure that they're getting sterile needles, and have an invitation, if they want, into treatment. And the only way that so it's wonderful that the New York Times is publicizing this, but the next step is for people to actually care about it, because to the extent that we all just walk out of this room and we don't make our voices heard, that we want to see solutions like that embraced, then it makes it easy for dollars to flow into fighting those systems and for the United States to remain a backwater on this whole policy front.
So, Harry, I'm going to ask you a question. We're going to wind it up because we're kind of at the end. I would love to keep going. I'm going to ask you a question. Can you put together for us, and we will disseminate it to everybody, the congressional committees and representatives that we should really reach out to get them at least talking about something different, and the insurance companies, how to reach out to them about this kind of thing. Even just having the conversations, not even changing anything yet. Could you do that for us?
It'd be my pleasure.
Great. I'm going to turn it back over to Janice Kaminer-Resnick, and I want to thank everybody, and most of all, let's thank Harry Nelson. And maybe a little bit of thanks to Harriet Rossetto.
I'm going to take the chairperson's prerogative and ask our panelists one last question. This is not a political statement or organization. Harry and Harriet, I'm asking you, being so knowledgeable about this subject, and also being so informed. Is there, without endorsing candidates, is there a candidate on the Democratic side whose policies on this issue you feel is it would be helpful to the commitment to reduce the opioid crisis in America?
That's like you swallow this poison. No, look, I think there's some. I think when I'm very impressed with the policy perspectives being put out by Amy Klobuchar in particular. She has been particularly focused on this issue. I think that Elizabeth Warren has done real work on it. I think that, but I honestly, to tell you what I really think, is that I think there are lots of really creative and interesting ideas being put out by candidates that have a 0% of success, because even if the Democrats swept both houses of Congress so that we could have a moment like 2010 when the Affordable Care Act passed, they would be fighting the insurance companies and employer groups who are so invested in our system. So I think that there's really good ideas to look at. I think Amy Klobuchar in particular really has spent time and has a lot to add on this, but I think we need to just figure out what we can take for those ideas and apply them in the real world, where we've got a lot of entrenched interests against real change.
Harriet, nothing more to, you're speechless?
I don't have any better ideas than that.
Well, one of the ideas I have after today, I think this has been an incredibly thoughtful conversation. And I have two thoughts. One is the importance of mainstreaming this issue in our synagogues. I mean, this is a Jewish organization. And it feels like sometimes problems feel so huge that it's hard to think about solving them. But if we focus on Los Angeles rabbinate and getting our rabbis and our community leaders to be more focused on the reality of opioid addiction in our communities. I know when my son first came into Beit Tshuva, which was 8 years ago, and I was very open about it because I didn't really feel like it was my fault. And I think so many people feel that when their kids are in trouble, it's their fault, that they don't like to talk about it in a sort of narcissistic way. Their shame prevents them from sharing with other people. So I think the idea of making our families' addiction problems more public and less shameful will have a big impact. But that's a huge job. But I think it's something we can actually do at Beit Tshuva. And the second thing I'm thinking about, especially after this morning's article in the New York Times, which I commend to you as well, Nicholas Kristof's article about Seattle, is to start thinking about what we can accomplish here with our local government and with local programs. And there is a lot of money right now because of all the homelessness initiatives that we may be able to capture part of that locally and give thoughts and ideas to our local government about things that we can do locally without having to feel overwhelmed by DC policy. So, I mean, if you'd like to comment on that as a final comment.
I had a conversation with the mayor's office. The mayor's office is very focused on homelessness, as you say, and I think getting them to see everything that we've talked about today as adjacent and part of that conversation is something that I think the mayor hearing that would open up more local activity.
And I'd like to address the synagogue issue. I think that the Elaine Breslow Institute now and its immersion training program for clergy and clinicians and medical professionals in terms of conversation about these issues. We've had several hundred people come here from different communities who want to
and
bring,
only 5 LA rabbis.
right? Who are bringing back to their communities a willingness to open up this conversation. And there's small successes. One synagogue was so proud that on the Measurable list, they named people who were suffering from addiction and mental health issues, that was a big, almost revolutionary willingness to surface this. And it's slow because of the shame and the hiding.
So I think those are things that we can work on. We're uniquely positioned to make that impact. But I also want to keep in mind what Harriet said before, is that we will continue to make our impact person by person, because we never lose sight of that. There's that wonderful story that you all probably have heard a million times about the little boy on the ocean, and he was walked by, and there was an older man who, one by one, had this big pile. All the starfish had been shored because of a low tide, and there was just a big pile of starfish, and the old man was throwing the starfish back into the sea. And the little boy said, "But there's this whole pile of starfish. You can't possibly get them all back before they die." And the old man picked up a starfish and threw it in, and he says, "For that one, I made a very big difference." And I think we will continue to see the importance, the ultimate importance of helping individuals, like so many of the people in this room, like my family, and like maybe some of your families as well. So with that, I want to thank you all for being here and for sharing today with us, and thank our panelists for this amazing conversation.